Hello, and welcome to this podcast on abdominal radiographs for podmedics.com. Although the plain abdominal film is often considered to be of comparatively little diagnostic value compared to a chest X-ray, and is now often overlooked in favour of a CT, it can still be of critical importance in the acute setting and one of the most commonly ordered films. As such, it is important to have a full understanding of what it is that we're looking for when ordering plain abdominal films and when it is appropriate to do so. In this presentation, we shall first cover some of the basic principles of plain film radiography with respect to abdominal films, and then shall look at some of the key pathologies that we look for when assessing them, and some too that are most likely to come up in exams. It's important to remember that an abdominal X-ray is quite a significant radiation dose and is equivalent to about that of 50 chest X-rays, each of which is equivalent to 1 day's background dose of radiation. As such, if you're ordering serial plain films on a patient, it can be cumulative and have quite a significant radiation dose effect. Thus, it is important that each film is maximised in its usefulness by fully understanding what it is we're looking for. As I'm sure you remember from the podcast on chest X-rays, there are 4 basic radio densities you need to know about when assessing plain abdominal films. Gas shows up as black on a plain film, and in the context of abdominal films is important when looking at intraluminal and extraluminal gas. Soft tissue shows up as light grey, fat as a darker grey, and bone or metal shows up as a bright white. It can be particularly useful when assessing the lower thoracic and lumbar vertebrae and the sacrum, as well as looking for calcification within the abdomen, such as gallstones, renal stones, or calcification of the aorta. Abdominal films are usually done in the supine position, the patient lying flat on their back with an anterior-posterior projection. If a film is not otherwise labelled, we can assume it is taken in the supine position. An erect film, with the patient standing, can often be used in cases of suspected bowel obstruction as air fluid levels, which become present in the stasis of bowel obstruction, can be more easily discerned. In sick patients who are unable to stand, the decubitus position, either with the patient lying flat on their back, with the film taken from a lateral position, or the patient lying on their side, with the film taken from a lateral position, both of which can be used to assess for air fluid levels and pneumoperitoneum. As with assessing any plain film, it is important to start with the basics. The name of the patient, his or her age, the date on which the film was taken, the gender of the patient, and the position in which the film was taken. You can also comment on the positioning of the film and its penetration. Commenting on all of these things will also give you more time to actually look at the film and assess what you think the most clear pathology is. In the context of exams, this can be very useful, as you will be giving the examiner some information without actually telling anything that you have to actually look for. So in this film, we could see clearly stated the patient's name, gender, date of birth, and the position in which the film was taken. We can comment on the fact that the entire abdomen is clearly visible and that the film is very nearly well positioned, though there is a slight shift to the patient's left side, with some of the right iliac crest not being clearly visible. but otherwise the majority of the abdomen is in the centre of the film. The spinous processes are clearly visible, indicating an adequate level of penetration. In this normal film, we can also see a normal distribution of bowel gas, with gas present in the left upper quadrant area of the stomach and also in the rectum, and predominantly in the large bowel, although we shall come on to bowel gas more detail in just a moment. Now we shall focus on some of the key aspects of a plain abdominal film that we look for. The first and usually the most clear abnormality in any plain abdominal film is the distribution of gas within the film, be it intraluminal or extraluminal. The distribution of gas can be a clear indication of both small and large bowel pathology. Small bowel is usually centrally located and has the presence of valvae conniventes, lines which cross all the way across the bowel. Large bowel is predominantly peripherally located, with haustra crossing 1/3 of the distance across the bowel. It is usually less than 5 centimeters in diameter, and there are few loops in the large bowel, whereas the small bowel is usually less than 3 centimeters in diameter and is often distinguishable with multiple loops. In truth, bowel itself is most clearly visualized when there is some pathological change. As we saw from the normal film, all of the bowel is not clearly discernible when the film is normal, but as we shall come on to see, when there is a change of pathology, both small and large bowel are more easily distinguished. In this first film, we can clearly see some dilated loops of bowel. These loops are predominantly peripherally located, and there is the presence of haustra, lines crossing 1/3 of the distance across the bowel. We can also see in this film a clear cutoff at the ileocecal valve. This is demonstrative of what is likely to be a mechanical large bowel obstruction, as the ileocecal valve will contain the dilatation of the bowel to just the large bowel. It is rather like a stop valve and does not allow the gas to escape into the small bowel and to dilate it to make it clearly visible. You may be asked in the exam what you think the cause of this might be. A common cause of large bowel obstruction might be malignancy. By contrast, in this second film, we can see dilated loops of bowel that are predominantly centrally located, with valvae conniventes running right the way across the bowel. This film is likely to be consistent with small bowel obstruction. And we can see multiple loops, also more likely to be consistent with small bowel. As we saw before, there is a clear cutoff at the ileocecal valve, which allows no gas to pass into the large bowel, and there is no gas clearly visible in the rectum, indicating obstruction to the gas, stopping it from passing into the large bowel. In this third film, we can see both dilated loops of small bowel in the centre of the film, with valvae conniventes present, and abnormal gas pattern in the periphery of the film that looks to be consistent with large bowel dilatation. The presence of both abnormal distension in small and large bowel is most likely to be consistent with paralytic ileus. There is no presence of a cutoff between the small and the large bowel. Paralytic ileus is a common complication post-operatively, and patients who have symptoms of obstruction, such as abdominal distension, absolute constipation, and vomiting, post-operatively, may well be suffering a paralytic ileus, in which the bowel effectively ceases to transit. Other causes of this can be electrolyte imbalance, hypothyroidism, and excessive opiate analgesia. Another cause of abnormal intraluminal gas pattern can be the presence of a volvulus. Patients presenting with a volvulus may present with symptoms similar to that of obstruction. A volvulus can commonly occur idiopathically in older patients and is due to the twisting of the bowel upon its mesentery. In this film, we can clearly see the coffee bean, or the so-called bent inner tube sign, as a extremely dilated single loop of bowel within the abdomen. This loop of bowel appears to arise from the left iliac fossa and runs up towards the right upper quadrant before turning and coming back down. This is most likely to be consistent with a sigmoid volvulus. Whereas, however, in this film, we can see once again a large, single, dilated loop of bowel, but in this case appearing to arise from the right iliac fossa, running up towards the left upper quadrant before turning and coming back down. As it arises from the right iliac fossa, it is more likely to be consistent with a cecal volvulus. So, having talked about intraluminal gas patterns, we shall now move on to talk about extraluminal gas. The presence of extraluminal gas in a plain abdominal film is nearly always pathological. However, patients who have recently undergone a laparotomy may demonstrate some gas within the peritoneum. In patients for whom a perforation of the bowel is suspected, the most effective diagnostic film is an erect chest X-ray, in which gas may be seen beneath the right hemidiaphragm. However, in a plain abdominal film, the presence of gas, as indicated by black shadowing on both sides of a bowel wall, is a clear indication of the presence of gas within the peritoneum. This is referred to as Wriggler's sign. Causes of gas within the abdomen can also be due to biliary fistula or pneumobilia following an endoscopic retrograde cholangiopancreatography, cholangitis, or necrotizing enterocolitis. But most importantly, a perforated abdominal viscus. Finally, we shall look at some films which demonstrate calcification within the abdomen. Calcification, as we have said, shows up as white on a plain film. In this film, which may at first glance appear to be a poorly positioned and poorly penetrated film, we can also see the presence of intramural thickening and calcification overlying the lumbar region. This is most likely to be consistent with an abdominal aortic aneurysm. In this second film, another clear pathology can be seen. In the right upper quadrant, a number of small white lesions which are likely to be consistent with multiple gallstones. It should be remembered, however, that 10% only of gallstones are radio-opaque, and so an abdominal film is not used diagnostically to look for gallstones, and the only accurate test is an ultrasound scan. However, in renal stones, 90% are radio-opaque and can be discerned on an abdominal film. However, a KUB film is more appropriate, and the film is repositioned in order to accommodate more of the pelvis and thus demonstrate the kidneys, ureters and bladder. This will also often involve the injection of contrast to create an intravenous urogram, in which case a number of films will be taken. A film immediately before the injection of contrast, called the control, a film taken immediately after the injection, at 20 minutes, at 60 minutes, and pre and post micturition. If shown a film that has this appearance of contrast within the distribution of kidneys, ureters and bladder, it is important to ask for a control film with which to compare it. In this film, we can clearly see the presence of an obstruction within the left ureter and a standing column of dilated ureter with the presence of contrast above it, a hydronephrosis and clubbing of the renal calyces, all of which are consistent with a ureteric stone causing obstruction. On the right, however, we can see the presence of contrast within the ureter and the renal pelvis and the calyces. The lack of presence of contrast throughout the length of the ureter may not be pathological and may be due to the peristaltic movement of fluid along the ureter. Hence why serial films and a control film are considered so important. Finally, an abdominal film is often used to assess for foreign bodies, particularly in accident and emergency and in paediatrics. This film is a good example as it demonstrates multiple foreign bodies in a patient who has swallowed a number of objects, including several bracelets. We can also incidentally see the presence of an intrauterine device within the region of the pelvis, and two other radio-opaque lesions in the right upper quadrant, which may represent pins. And finally, very few surgical nights are complete without at least one admission with a foreign body per rectum, and this film is surprisingly common in accident and emergency, and we can clearly see the presence of a foreign body within the pelvis and likely to be lying within the rectum. And superiorly to that, we can see mottling consistent with fecal impaction, suggesting some degree of obstruction. However, we can also see the presence of gas within the rectum, suggesting that this obstruction is not absolute. Thank you for listening.